direct close contact with large respiratory droplets, inhalation of smaller respiratory droplets that we call aerosols, or indirect contact of your hands and then touching your eyes, nose, or mouth of a contaminated surface. So what happens is then the more people there are in a given space, the more likely that you're going to come into contact with someone who may unknowingly produce infectious droplets or aerosols, or if they sneeze without a mask, it might end up landing on a desk or a surface. And so that's why the higher the density, the more people there are in a given space, the higher risk and higher probability you are at coming into contact with someone who may be infectious. And this is assuming that anyone with symptoms stay home. But we know now that you're actually most infectious just before showing symptoms and at the start of your illness. And so if someone unknowingly is infectious, the more people, the more crowded the classroom or schools are, the higher likelihood that more people will be exposed, which means then we are at a higher risk of getting super spreading event if the classroom is crowded.
Okay, that makes perfect sense. Either of the other two have anything to add on that first question?
Well, I think I would just add that the air exchange systems in our 771 schools are quite variable, I think, in terms of their vintage and their capacity. So by contrast, for instance, I mean, we can elect to fly on an airplane if we feel we need to, but it isn't essential to most people's daily lives. But you are jammed in on an airplane. On the other hand, the air exchange in an aircraft exchanges that air about every 2 minutes and puts it through HEPA filters. So we don't have that sort of capacity to rapidly do air exchanges in schools and put them through filters that could trap the RNA from the viruses.
That's right. Dr. Anderson, anything to add on this one?
I think one thing to add about just going back to school is if you think about all of us have been keeping our social circles quite small, 5 people, 10 people, things like that. If you have 30 students in a classroom, each of those students is probably accessing their parents, caregivers, siblings, maybe 2 or 3 other people. So your child, in essence, is being exposed to maybe 100 different people just in that room because they were in contact with someone else that morning, the previous evening. So there really is going to be this sort of lack of control of our social circles once we're back in school because we have so many more connections that are going to be happening.
Yeah, it's like our children are learning multiplication in a really dangerous way going back to school, aren't they? All right, on to our next question. Dr. Kendel, this one is going to be going to you first. Can you explain to us, we've heard so much about it, asymptomatic transmission, asymptomatic, and
right,
how it relates to children and COVID-19?
Yeah. So our advice to everybody, if you feel you have symptoms, if you have cough, fever, a variety of symptoms, they're well known by now, you stay home. But unfortunately, the virus is transmittable often before people develop these symptoms. And it's interesting that children are somewhat less prone to get seriously ill, but they're no less prone to actually be carriers of the virus, at least the older age kids. And so we have a lot of kids going to school. They seem healthy in the morning, and they may though be virus carriers, and they may in fact spread the virus before they actually develop symptoms. And that's true in other workplaces and public places as well.
Got it. Dr. Huang or Dr. Anderson, anything to add to that? Pretty straightforward, I think. It's what we've been hearing in the media over and over. All right, question number 3 to Dr. Huang. I feel like I'm not getting your name right every time, so jump in.
It's perfect. No,
Okay.
it's perfect. No, it's
Okay.
good.
Now, we touched on this already in our first couple questions, but we're going to go back in and go a little bit deeper into it. How does aerosol transmission occur, and how does ventilation in a classroom play a role? We talked about the airplane scenario just now. Is there a certain type of portable filtration system that could be used in classrooms without adequate ventilation, which we know many classrooms don't have?
Right. So first of all, I like to separate what hospital infection prevention and control specialists may define aerosols and airborne transmission versus what I'm talking about right now.
Okay.
So what aerosol by definitions are anything that can remain suspended in the air, whether they are liquid, solid, or any type of mass, any type of particle. So what we know now is that even when we're speaking, we are generating thousands of tiny respiratory fluid microdroplets that are termed aerosols. And up to about 50 micron diameter of these microdroplets can in fact remain suspended in the air from minutes to hours, depending on the humidity and the relative humidity and the temperature in the room. And if there's air current within that room, then the plume that contain infectious COVID-19 virus could then be dispersed at a distance from the infectious person. What the data is showing right now is that COVID-19 virus could be spread this way because there's a recent study that showed that even within a hospital setting with excellent ventilation and filtration, they were able to isolate genetically identical COVID-19 virus at a distance more than 6 feet away from the patient. And that virus was found to be viable, meaning it was still alive. They could replicate it, and subsequently that air sample, the virus that was collected from that air sample can in fact infect a cell line in the lab. So aerosol transmission is essentially another way of saying that this virus can be transmitted through the air, encapsulated within these microdroplets. And so what that means is that if, Dr. Kendel alluded to it earlier, if we are outdoor, then it means it's like dropping a drop of dye into the ocean. That gets diluted very quickly. But if we're indoor, then imagining kind of dropping a drop of dye into, say, a beaker or a smaller bucket. And so the concentration is greater. And that's why then in indoor setting, if we could then improve the air change rate with clean outside air, that will essentially dilute any potential viruses that may remain in the classroom if anyone is infectious.
Right.
And then I think there was a third part, the portable. So I think the question was about portable air cleaner, correct?
Yes.
So if we were to improve the ventilation, like Dr. Cantor alluded earlier as well, there are many different types of HVAC system, and it's important that the specialists that maintain that are consulted for improving the exchange rate with outdoor air and adding the filtration, at the best sort of filtration efficiency you could. But if that isn't immediately possible, then one of those portable air cleaner with HEPA filter actually would be able to reduce the amount of potentially infectious aerosols that remain in the room. And so the HEPA, HEPA filter, if they're certified, have actually been shown to be effective at filtering these small micro droplets and viruses as well. Yeah,
that is encouraging that we have that ability to have those portable filtration systems, that they do help.
And the only thing I think and I think if we're going to be talking about that, I imagine we'll be sort of speaking with the specialists a bit more. But one thing to remember is that you want to avoid blowing any of these added current from one person to another person. So in case someone is infectious, you don't inadvertently spread their tiny respiratory droplets around the room.
Right. Okay. Dr. Kendel or Dr. Anderson, anything to add on that point with filtration?
No.
No. All right. Thank you very much. That was very detailed, but I could understand it as a parent, so that's important too. Fourth question, and this is directed to all of you, and this is one that has come up with me as a parent as well. And we're talking about lunch at school. So will there be extra risks from having students eat lunch in the same room together? Obviously, that mask is going to need to come off to eat lunch. Are there ways to make lunch and snack time safer at school? And this is open to everybody, whoever would like to take it.
If students are going to be,
you go ahead, Alex.
if students are going to be wearing masks while they're taking their lessons, then that's going to reduce the amount of, or the concentration of virus in the air. But when students are eating, obviously they're going to have to take their masks off. So something that we could potentially think about is during the lunch hour, if you had half the students eat lunch at the start of the lunch hour and the other half go out for recess, and then you alternate them back in, then you would at least be able to double that social distancing of the students who are in the room and eating. Trying to minimize the amount of time that our students are eating, making sure that they're putting their masks on when they're done, making sure that they're not sharing food, sharing drinks, any of that stuff. But I think that that's probably a fairly set thing that nobody's going to be doing that anyway.
Right. Let's hope. That's a great idea.
The other thing I would just add, probably people saw online the Pasqua First Nation showed their school, and they've actually got these, plexiglass shields around the desks. And I mean, if each student brought their own lunch and they eat in their little cubicle with plexiglass around them, the risks are probably minimal. But as Dr. Huang was saying earlier, it's the droplet generation that is an issue. And you remember way back, our Prime Minister talked about speaking moistly. And so during lunch hour, if students are in groups and they're facing each other and they're chatting a lot, it isn't just the food, it's the fact that they now are in close proximity and they're creating droplets and aerosol. So it depends how you consume lunch. There's relatively little risk of virus transmission through the actual food itself.
Okay, so we want to create as much social distance as we can during those lunchtime eating periods when those kids don't have those masks on. Dr. Huang, anything to add on that point?
I was gonna just suggest that even the foldable dividers, so kids in Asian countries and the CBC marketplace actually show a segment of this where at lunchtime, then there's these sort of foldable divider that they could put around the kid. So for older kid, if they're okay eating on their own, that will reduce the direct sort of larger droplet transmission. And if possible, then the sort of conversations and speaking and sort of that face-to-face sort of close contact can be minimized. That could also minimize it. I mean, it's a bit harder for children, but it's really not, it's not a full-born virus. So it's not actually the food, it's the context when we have meal together that is the risk.
Okay. That makes sense. I am getting a follow-up question from parents in the chat are asking, back to the air purifier conversation we just had, would you recommend that teachers look at purchasing an air filtration system, the portable ones, for their classrooms, the HEPA filter portable systems? Is that something that you would recommend?
If I were the teacher, I would be looking at it myself personally, particularly if my school building is older and if it's if the airflow hasn't been ideal in the past. Yes.
Okay.
I just want to say that I think anything you can do to incrementally reduce risk is potentially worthwhile. But I think we have to be realistic. A lot of these portable air cleaners with HEPA filters have relatively low capacity. So, you know, they're meant to be operational in a small room. So their impact in a large classroom might not be as great as you think.
That's a good point. So these are typically by parents. We use them in a bedroom for a child at night, right? Okay.
Yeah. No, that's accurate. Like if we have a portable HEPA filter and place it in the gym in a large open space, it wouldn't have much impact at all. Yeah.
Okay. Important to note. Thank you for that. Dr. Anderson, you're up next with our next question. It's a biggie too. Why is testing so important, and is voluntary testing sufficient?
So with children and really with adults as well, the amount of asymptomatic or length of time that people can transmit while pre-symptomatic varies, but a sort of nice standard is about half of kids will not get symptoms or may transmit for an extended period of time before they get symptoms. So if all we're doing is temperature screenings and symptom screening with kids, what we're going to find is that that might catch half of the initial cases, but it's the asymptomatic kids that are going to then spread, and they will create more asymptomatic kids. So I think that our current sort of reproductive rate, if you know, we weren't doing any sort of controls, is that one case is going to generate about 2.4, which would mean, and sort of again to add to that, they think that 80% of cases are created by 20% of cases. So if you had 10 sick students, 2 of them will do 80% of the transmissions, and 8 of them will do the other 20%. So 10 kids are going to make 24 kids sick.
Wow.
2 kids make 19 kids sick. The other 8 kids will make 5 kids sick. And it's those asymptomatic kids that become these super spreader events where you could have one transmits to several. If they're all asymptomatic, they transmit to several. And it takes a while before we have someone with symptoms to test. And then we can trace and track all of the other asymptomatic cases because hopefully they've been in contact. But if we're just doing voluntary testing, we're only going to find the cases that actually have symptoms or the parents who are actually taking their kids in, which if we're not doing a lot of screening, we really might miss these before they have a chance to blow up.
Either the other 2 of you have anything to add on that one? We're good. There is a follow-up to that, Dr. Anderson, and that is on pooled testing. What is pooled testing and how is it more cost efficient?
Okay. So pool testing is not a diagnostic test. It isn't done on one person to see if they are COVID positive or COVID negative. What it is we are going to have several tests, and there have been protocols published for up to 30 where they've sort of tested the sensitivity. And what you would do is you would have 30 swabs collected or 30 saliva samples collected, and all of those get aggregated into a single sample. And then that will be tested to see if it's positive or negative. If it's a negative test, then that would presume that all 30 of the kids in that class or all 30 kids in the pool are negative. And then you don't have to do 30 individual tests to find out their COVID state. If it's a positive test, then you need to actually go and test each student individually to find out which, if any, are positive. There is a chance of false positives, but because this isn't diagnostic, we would then make sure we go and check every student one by one.
So
and this is a way to sort of boost our test capacity.
That does sound to me then that it is more cost efficient then to go that route. Okay, thank you. Question number 7. We've made it more than halfway, guys. Thank you. And we are now at 152 participants. So won't get you guys too nervous knowing that. Thank you to everybody that is participating right now and listening in and sending in the questions in the chat. Number 7, this is for the entire panel, so whoever wishes to jump in, go ahead. It's another biggie. How will the reopening of schools change those social bubbles? With schools opening and classrooms at full capacity, will large crowded classrooms aid in community transmission? I mean, I know we know the answer to this, but we want to hear it from you.
Well, I'll start. It certainly increases risk. And I think there was reference made earlier to having to connect the dots between bubbles. So I was somewhat dismayed earlier this week to learn that in various sports activities that kids take part in, the current regulations provide for these mini leagues that can involve up to 50 people. Those would be players, coaches, not parents observing. Yep. 50 people. And there's no requirement for distancing between a total of 50 people. Now, doesn't mean a child is in contact with 50 people simultaneously, but during the course of being involved in these sports, that's how big that bubble is. And then you multiply that by your classroom exposure. You go to visit your grandparents, and you know, it isn't just the risk to the children. Then you're bringing the virus into your other familial bubbles. So it's a significant risk.
Absolutely. Dr. Anderson?
How I sort of think about this is that if we didn't have schools open, COVID cases might be restricted to a workplace or a geographic location, all the people using the same convenience store or going to, you know, the same doctor's office or things like that. But it's probably going to be linked where people are in proximity. Once schools are open, you have a case where a student might get sick from their parent working at, you know, some accounting office. They take it to school, and if multiple kids get sick, they take it home, and then their parents might get sick, take it to their workplaces. And we have sort of like when cancer metastasizes, we can get these sort of little pockets of virus that are now spread out through the community, and each of those has a chance to germinate and accelerate and affect more people, because students are sort of this backbone that links us all together, because all of these kids are sitting 8 hours a day, 5 days a week, 30 students at a time in the same room, and essentially they're swimming in each other's respiratory droplets if we aren't sort of controlling it.
Yes, that's a very good point. Dr. Huang, anything to add on that?
I just want to comment on the fact that the cumulative total cases that have unknown source of exposures have actually been increasing in its proportion. So what that means is we actually have a larger proportion of cases. We do not know how they contracted the virus, which means further effective contact tracing couldn't really be done, you know, as effectively. And so we're actually at a higher rate of community transmission level right now than a few months ago when Saskatchewan first started reopening the business and economy. And with prolonged exposures of large group of students and teachers and staff who may be high risk and more vulnerable than students, we should expect, if there's an infectious case introduced into that setting, we can anticipate a faster growth of the case count should that happen.
It sounds to me as well from what you're all saying, and Dr. Anderson, you touched on it quickly, is contact tracing seems to be like it's going to be very, very difficult to do once children are back in school. As you said, they're the backbone that connects us all. Right now, we kind of have pinpointed places where we can contact trace, but once school plays into that picture, that's going to become an even bigger job. Is that right?
Yes, and plus once our case numbers go up, as they would expect to do as we get into the fall, our contact tracing is going to become even more limited because you're going to have more exposures, more cases, our contact tracers are going to be overloaded. And you know, really, if we can keep it contained as long as possible, that's going to protect us. But once things sort of, you know, escape like it has in the US, there's almost not a point of doing some contact tracing when 1 in 5 people that they test is positive. If they've got, you know, 20% positivity rate, it's just, it can't be contained with the same kind of measures.
That makes sense. Let's see, we're at number 8. This is for Dr. Huang. For the past several months, we've been told by medical experts to maintain that 2 meters physical distance between ourselves and those who are not inside our bubble. What are medical experts recommending now? And if you ruled the world, if you had to recommend a maximum class size, what would that class size be?
So I think we are aware that the virus hasn't changed. And so the need to maintain that physical distance of 2 meters to reduce our exposure to direct contact with large respiratory droplets has not changed either. So this does mean that the classroom is actually a high risk sort of setting for transmission if anyone is infectious. I don't have children myself, and I'm not familiar with the primary school or secondary school classroom size here. And so I think in terms of classroom size and students, I can only say that the fewer, the better. That could be logistically handled. But and that relates to sort of the airflow. So if we have improved ventilation, such as the setting in hospital where they have higher air exchange rate and better filtration, then you can afford to have more students. But if you don't have that, and in fact you have the opposite of sort of recirculated air with very little fresh air to dilute the aerosols and droplets in that space, then the fewer students and teacher staff room using those space at the same time, the better.
Okay.
So someone else may be able to provide a number better than I can.
Sure. Why don't the two of you jump in? If you could actually state how many kids you would like in a classroom in Saskatchewan this fall, what would that magic number be? Dr. Anderson,
I don't think that there is a magic number.
Okay.
I think that it's not an easy decision for any parent to think about sending their kid back to school. And I know that for me, I'm going to be teaching classes online at university, so I'll be home. And if case numbers go up at my school, my kid's school, I can have them stay home and sort of have that flexibility. But I know that some parents are not going to be able to do this. They're single parent families, they work shift work, they have jobs where it's critical that they have to go and be there, and their kids are not going to be able to look after themselves. And those parents have to send their kids to school because there's no other way. So I think that what we could think about is just, how can we limit the number of students in classes? We could think about things like alternating days or having sort of cohorts that way, where even if only some of the parents can keep their kids home a day a week or 2 days a week, that could lower the overall number of students in the classroom by 10%. 10% fewer students breathing, 10% chances of transmission. It's something that can sort of limit it. And we sort of need to think about it as each little thing. If we're wearing masks, that lowers it a bit. If we can improve airflow, that lowers a bit. If we can space them out, that lowers it. If we can do more classes outside, that lowers it. And just think, each one of these levers that we can sort of pull on to slow down the spread is something we should be trying to do from the very start. We shouldn't be saying, well, we could institute these other measures if things get bad. Because once things get bad, really we only have the option of shutting down the school or shutting down that class, quarantining everyone for a couple of weeks to make sure that we've sort of had all of the cases go, any infected students are now COVID free. But, there's no single solution. It really needs to be every individual little thing, because the only one solution that works would be keeping all the kids home. And if that's something that we're not prepared to do, and that's something that some parents absolutely can't do, then we need to try and use everything else at our disposal.
I do like that it's a culmination of all these things added together that's going to give us our best defense. Anything else to add to that, Dr. Kendel?
No.
No. Wonderful. This next question is for you, Dr. Kendel, so now you're ready. Many educational assistants in our systems and primary teachers, they're worried about the lack of physical distancing in classrooms, which we've been talking about. With small children, educational workers often work in very close contact with hand-over-hand instruction or even help with bathrooms. How can teachers and educational assistants protect themselves?
Well, that is a very difficult question. I have a good family friend who is an educational assistant, and when I listen to her describe how she works with the selected students she's assigned to work with each day, it's very close. There isn't a way to actually help these students that you can, stand off and not be proximate. So unless we're going to somehow find a different way to accommodate those students in different settings, the only things to rely on are things like masking and, trying to maintain distance as well as you can. I haven't been in a school for a long time, but I have lots of friends who are teachers and EAs, and they were very disturbed when they heard some people saying that the teachers would just stand at the front of the room and lecture. I don't think that's the way education happens today, from my understanding of the teachers' experiences, and even more so with EAs dealing with very special needs children. You have to be proximate, and there's just no way around that.
It's very true. And we're hearing a lot about children facing forward in their desks all day long. I don't know if anyone's been in a classroom lately to know that children do not do that all day long.
Not for long, no.
Not for long. Next question is for Dr. Huang, or you, Dr. Kendel, as well. Of course, Dr. Anderson, feel free to jump back in. Back to educational workers and parents in this case. They're concerned about isolation rooms. This has been a topic that has come up in the back to school plan. Staff are worried about supervising students in these rooms, and parents are nervous about a child with allergies or a runny nose having to be isolated because they are showing particular symptoms, isolated in that room with another child who is isolated in that room, and maybe that child is going to then test positive for COVID, and you've put them in an even smaller space. So I don't know if you can answer this, how will teachers be able to tell the difference between a child with allergies and a child with COVID symptoms? And what do the staff supervising these rooms, what do they need to know about keeping themselves safe? Should they have very specific PPE when they are going to be in those isolation rooms?
I don't think it's fair to expect the students or the educational assistant to diagnose and differentiate whether a child has allergy or potentially COVID symptoms, particularly in the next few months when the seasonal flu season begin. We're going to have another respiratory virus that's going to present with very similar symptoms. So I think definitely surgical face mask, which provides better filtration, and than sort of the homemade mask in general.
Okay.
And ideally also, if the teachers are not wearing glasses, ideally a face shield as well. So think about if a triage nurse at the emergency room, having the surgical face mask and the face shield to do the screening, even just talking to people coming in. I think that should be the level of protection that we provide. And in addition, I think there needs to be a clear mechanism as to how long the students would have to wait in those rooms if the parents are not available to pick them up right away. And so I do think there's an important role for additional support of outreach school nurses to assist with these situations. Because I don't think it is fair to expect the educator to actually look after children when they may potentially be sick for any prolonged period of time. I think the idea was great to sort of segregate these children from the class until someone can pick them up, but I think more detail need to be considered to ensure that suggestion is actually a safe option.
That makes perfect sense. Dr. Anderson, do you have anything to add to that?
Like I had allergies my whole life and still do. And I think that, it is something that is predictable. And I think that for parents who have children, who consistently have, or even routinely sort of coming back every once in a while, symptoms of some kind, there could be some record saying this kid commonly has a runny nose. This is something that we know that they've not been exposed. They've been isolated for the last 5 months. And just to say that that in and of itself for this particular student will not be adequate symptoms presenting to say that there's something different about them right now. But again, that needs to be tracked, right? I think that a good idea might be that there would be, a folder that the teacher has saying, these are the students and the symptoms that they might routinely get, just so that they can try and not have to isolate students over and over again.
Dr. Kendel, anything to add, please?
Well, I would just reinforce what Dr. Huang had said about the fact that my understanding of these isolation rooms is not that there's an intention to keep their children there very long. So as has been the case forever, if a child gets sick, you phone the parents and ask them to pick up the child. And I do think this is part of the, the arrangement with parents. It's going to have to be understood that somebody has to respond fairly quickly to pick up the child. It's unfair to leave that child in an environment, with a teacher unnecessarily long.
Yeah, and I really appreciate you bringing that up, Dr. Huang, because that has been a common discussion among parents and teachers is what happens if you cannot reach the parent or the emergency contact, and there are concerns about that. So that is definitely something that needs to be addressed. I also appreciate the additional PPE information for teachers that are going to be in those rooms. I think that's worth noting as well, that they're going to need more than the bare minimum. It kind of touches on the next question, which is bare minimum. And this is to the entire panel. I'll start with you, Dr. Huang, and then we can work our way through everything. But it's another loaded question, but what should be in place for schools to start safely? What is your absolute must be in place for school to start?
Am I
That's
starting?
you.
Okay. I think there need to be very clear guidance on the use of face masks. I don't know, things have changed so much in the past week, I think in a good direction, but given what we know of the effectiveness of face mask use now, and seeing Toronto and Ontario having their case load drop quite significantly in the past few weeks, I don't think it's I don't think it's good advice if the government leave it up to the school divisions and the parents to sort of advocate for the need to use face masks in a school setting. So that should be there because we know it's gonna reduce the overall transmission risk. We talk about the need to reduce class size that provide the opportunity for physical distancing. And so I don't know how best to achieve that, but whether that's class size reduction, more teachers, use of alternative venues, we need to have that physical distancing still in addition to mask. And thirdly, we want to prioritize sort of where we may start, but it is important that that there are some assessment to look at the current status of ventilation and whether that could be improved at all or not. And in schools that ventilation cannot improve with existing HVAC system, I think it's important that the government supports the school divisions to purchase portable air cleaner. I don't think it's, again, I don't think it's fair for the educators or the parents to have to do this on their own when we already know the risk and we already know that these layer risk reduction strategies, so adding like everything reduce a bit of the risk, and when we know that this could reduce the risk, and if we choose not to pursue it at this point, I don't think that would be fair to the educators and the teachers and the parents going forward.
Thank you. I really appreciate you bringing up the point of alternate places and venues to have classes. That is another big thing that's been coming up with parents and teachers, and hearing it from somebody in the medical field. I think that's important to have that out there. Dr. Kendel, what would you like to add to that?
Well, I'm going to start from, as a citizen, listening to the very first press conference when the Minister of Education and Dr. Shahab jointly announced that the goal was to keep things as normal as possible. I almost fell out of my chair, because that is not how you mitigate risk of harm to people in a pandemic. You use every possible mechanism to reduce risk. And there has to be a minimum threshold at which, in a particular setting, certain risks are not acceptable, and then you have to go to alternative options, like moving to different venues or other things. So when I looked at the 4 levels, the contemplation that the expectation everybody would start at level 1 that didn't involve masking was just utterly irresponsible. Now, since then, the government has changed its position, and it's leaving it to the divisions, but recommending, that they begin at level 2. I think we should begin at level 2 everywhere.
Okay.
We've been told the government has ordered 6 million masks. Why on earth would we have masks sitting somewhere in storage and wait to see if an outbreak occurs? Use the masks. Use them universally.
Use the masks. I love it. Use the masks.
And whatever else you can do. So in some situations, I recognize that we have to deal with realities. And in some circumstances, you'll have very suboptimal buildings. And, there may be some buildings that aren't usable in the current structure, this current environment. But get away from this idea of saying that the objective is to keep things normal. The objective is to keep kids and teachers and staff safe. And you pull out all the stops to do that. Everything you can do, do it.
I love it. I think there's going to be a lot of quotes taken from your last answer there and used to come. Right? We agree. Dr. Anderson, do you have anything to add to that point?
So reiterate, yes, we should be doing everything that we can, and then sort of scaling back those safeties if we actually get confident that things are under control. But it's better to be overprotective first and then realize we did too much than it is to be underprotective and have outbreaks and then decide, well, what are we going to do now? I would like to see firm sort of criteria, circuit breakers of what happens if there's 1 case in a school. What happens if there's 2? Not we'll see and we'll decide, but I think there should be firm guidelines of if the positivity rate rises above this amount in this community, then we have to do something about it. And that takes the decision away from the administrators, from the teachers, to say that there is something where this gets triggered once you have a second case in a class. And that means that people can't say, well, I didn't think it was really that bad. We should have firm guidelines, not sort of rules that we choose to enforce or not enforce based on our own situation.
Right, and changing across the province with each school district and what they feel is right. I agree with you there. It actually leads me to the last question, Dr. Anderson. It's like you had cheat notes because you knew what was coming next. This is a question, again, that's coming up with parents and teachers. We keep using the term outbreak with schools. So what constitutes an outbreak, and what should the criteria that triggers those different measures to deal with the outbreaks within classrooms and schools? I know that we don't have clear guidelines on that yet, but asking the 3 of you this question: what constitutes that outbreak? What should that criteria be that triggers the next step? Are we talking 1 kid in a classroom is diagnosed and the classroom shuts down? Is there a certain percentage of kids in the school? What are we looking for? I'll go to you first, Dr. Huang.
Sure. For influenza sentinel surveillance program, in larger center, there's this arbitrary cutoff of 10% absence in the school setting. 10% absence due to influenza-like illness. But I don't think that's appropriate for a new pathogen and in a pandemic setting. So outbreak is defined as a rising case incidence or a rising of new cases above the baseline. And that's defined individually for each disease. We have not defined what outbreak would constitute in the school setting yet. And so that actually needs to happen first. So I agree wholeheartedly with what Dr. Kyle Anderson was mentioning earlier, that these criteria needs to be spelled out right from the get-go. So it's not a wait and see and scramble situation. Everyone needs to know this is what it means if we see this and that. And what I would propose is that when you have one case, if you, for example, if you have one case in a student or a teacher where you are able to clearly delineate that the exposure came from outside of the school and there had not been any connections that could have led to additional transmission within the school setting, that could be addressed as a single case, and contact tracing would be adequate in that situation. However, if you have the situation where you have two cases that are not, and we heard this term used in some of the SHA document, if they're not linked, what that means is epidemiologically linked, meaning that if there are no physical interactions or being in the same space that could have led to a transmission event to occur, so both new cases occurring around the same time with no known connection to each other, I would propose that to be an outbreak, to be an outbreak definition for the school setting, whether it be in the same class or different class, because there are all these shared communal setting that transmission could occur. So this is actually an important point that the province still need to work on, and they have not, they need to provide clear guidance on this still. But that's what I would propose.
Okay. Dr. Anderson, what would you like to add?
You know, I don't know what everyone would be comfortable with, but I know that if my kids had one case in their class, I would hope that every kid in that class would go and get tested.
Okay.
Because if someone in that class was testing positive, we know that at least a couple days before that, they may have been transmitting virus. And the students in that classroom, the teacher, the EAs, they all may have been exposed. Anyone riding on the same school bus may have been exposed. And I think that in order for us to try and get ahead of it a little bit, being able to proactively test each of those individuals and say, if no one else comes out positive, great, you can go back to school the next day after you sort of get your negative result. But it's our way of checking to see if maybe that isn't the first case in the class. Maybe that's the first one we detected that's symptomatic, and maybe there's actually multiple cases. And I think that until we've been running school for a while, we need to be especially cautious about these asymptomatic transmissions.
So very, very cautious in the beginning to make sure that we're catching all the asymptomatic transmissions, because we know what that turns into. Dr. Kendel, anything that you'd like to add on that last question?
Well, my friends who are lawyers use a term called time is of the essence. It means that temporizing and not making a decision, puts people at risk of harm. So I would agree with my two colleagues that to the extent possible, we need clarity as to what the definitions are going to be with regard to outbreak. The people involved, the public health officers, the public health nurses, are employees of the Saskatchewan Health Authority. And I guess it falls to the SHA to, as soon as possible, articulate some definitions. We've clearly seen when the SHA declares an outbreak, as has happened in at least one hospital, in communities like Hutterite communities, obviously, and many other settings. We've had a clear sense of what constitutes an outbreak, and I think we need to have that sense so that when it happens, everybody knows what will follow, that there isn't delaying for days to figure out, do we really need to do something? And probably, again, err on the side of caution.
Absolutely. We've come to the end of the 12 questions that we had, but we are getting such great feedback from the chat. And I want to tell the three of you that you are rock stars right now. People are so happy with you taking the time to answer these questions. And I do have two more that seem to be a consensus of questions that we're seeing. If you would just give me maybe another 5 minutes, if you don't mind, so I can ask you this. The first one is, I'm going to go to you first, Dr. Kendel, on it. Should every school have a school nurse?
Well, ideally, I would say yes. I can't say that I've been able to research the pragmatic reality of that, but I do think it would be a wonderful thing to have. I don't know from a workforce perspective. I've learned online that we have 771 schools in this province. I don't even know if we could muster that many nurses from the existing workforce, but it would be good to have somebody with nursing expertise attached to each school. It would.
Okay. Dr. Anderson or Dr. Huang, do you have anything to add to that?
I think that if the province is saying that they're going to have a more aggressive testing strategy, that having someone at the school above a certain size, so not for a 30 student one room schoolhouse, but if you have more than 100 students, having the capacity at that school to take a sample that day to send off for that student's testing, especially if they're having any kind of symptoms and we're feeling the need to isolate them, so that we aren't waiting for that kid to sign up to see if they can get tested, and maybe the next day or the day after we're going to be able to get that sample harvested, because any sort of lag is going to build in more transmission probabilities.
That only makes sense. Dr. Huang?
I think what I'm hearing is, and I think I would propose that whether there's a school nurse physically attached to the school, or that there's a dedicated nurse assigned to connect with the school administrations and teachers should there be any questions about students arises. And I think that in that situation, they may or may not necessarily need to be stationed in the school all day, but I think it's actually a great suggestion to at least create a clear contact point between the health system, the public health system, and the education system through a clear sort of list of school nurses, actually.
I think those are all great suggestions. Thank you. Yeah, go ahead.
Could I add something?
Sure.
So we have been promised there is going to be a big press conference tomorrow with Premier Moe and Dr. Shahab. And then on Saturday, Premier Moe did a little impromptu press conference in front of the school in Rosthern. And he did say there's going to be in-school testing. So I guess we'll hear more details about that tomorrow. But I don't know what that means, if there will be capacity in every school at some minimal response time to do testing. So we're going to hear something tomorrow about this, I assume.
Yes, we've been waiting for 48 hours to get the rest of that information, haven't we? Thank you. Dr. Anderson, this one is to you, and it's a little bit more about pool testing that we talked about in the beginning. And the question was, how many classes would need to have pooled testing done, and how often should that pooled testing be done?
So I think that the answer for how many is as many as possible. If you think about our provincial testing capacity as tests per day that can be done because of the equipment that actually runs the test, that is a limiting thing. We could perhaps hire more people to do it, but if the machines aren't there to run the tests, we can't build up beyond that. There's no reason that we should be doing less tests than we're able to do per day. So if we have essentially these surplus tests where we could put more tubes into the machine to amplify to see if it's going to be positive, we should be trying to use up those slots so that we can get this sort of surveillance done. Whether it is done with sort of randomly selected individual students or whether we're doing it with pools, just any kind of surveillance is going to allow us to find those asymptomatic cases before they trigger some kind of symptomatic event either in that individual or in the individuals that they infect.
Perfect.
And one thing to
yes,
add,
go ahead.
with the pool testing and just with testing, Just yesterday, the FDA approved a protocol from Yale, which is a saliva test. It only uses 50 microliters, 1/20th of a milliliter of saliva. And this is something that a student could easily spit into a tube. They wouldn't have to have the NP swab, something that's going to be really discomforting. This is something that students could collect themselves.
And we keep hearing more about that every day. And as with everything in COVID-19, things change day to day, of course. Safe Schools Saskatchewan is on Facebook. I think all of our participants that are in the chat are aware of it. That's why they're here. I will mention to everybody that is tuned in tonight, this is being recorded, so you'll be able to watch it later. And these 3 doctors who have given us their time, they are on social media as well. We have listed their handles on the Safe Schools Saskatchewan Twitter page. So if you go there, you'll be able to find these 3 and follow them, because they do have more information that they do share on Twitter. And they're quite enlightening, and I'm learning from them all the time. So it is 8 o'clock. We have spent an entire hour talking about this. I think we've got the majority of questions answered. And I want to take the time to thank you 3 so much again, because we are looking to you, parents and educators, grandparents. We need you, and we need your voices out there to help us mitigate this and figure out our way through. So we thank you so very much for taking the time with us tonight. I hope that you find some new followers online that are going to be probably asking you some questions there as well. But I appreciate you being candid, and I appreciate you sharing your thoughts honestly with us. Is there anything else to add? I don't want to cut you guys off in case there's anything else that you want to say before we say goodbye to everyone tonight.
Just want to do the Zoom wave.
We can do that.
I might
just
ask
wanna-
one quick question. So I saw
yeah.
someone had put through
We're
the
not
chat.
going anywhere. It's okay.
Someone in the chat had asked whether masks versus face shields and what's the sort of difference. If you think about your lung surface area, it's about the surface of a queen size bed. That is what the virus could stick to infect you. If you think about the surface area of your eyes, it is so much smaller. So a mask is way more important than a face shield if we're thinking about blocking routes of entry.
That's great. A queen size bed. Great. Now I'm going to be thinking about that tonight. Thank you for that.
And I just want to add that clarification of calling something outbreak it's a nomenclature, but it doesn't mean that, you know, when you have one case, you don't do the testing. And so they're 2 different things. So we need to have a clear definition of what constitutes an outbreak in school, because that would trigger a different level of response. But if there's just even the single case, as Dr. Anderson had mentioned earlier, there also need to be clear criteria on, are we now isolating the entire school? Are we now testing the entire school? The teacher, as well as the bus driver and the staff that have come into contact with that particular classroom or cohort. So I just want to clarify that those are the sort of routine public health investigation and contact tracing that needs to be done, whether the number of cases in a setting would be considered an outbreak or not.
Yeah, we definitely need more understanding of what that definition is and what it means going forward once that happens. Anything else to add? Now we'll do the Zoom wave. Thank you everybody for participating. Thanks to everybody.
Thank you for.
Bye everyone.
Thanks
You can
for
turn off
having
the
me.
cameras.
Thanks. Bye-bye.
Bye-bye.